Let's talk about diabetes insipidus today. Now, coming to the definition of diabetes insipidus, it is a disorder in which polyuria due to decreased collecting tubule water reabsorption is induced by either decreased ADH secretion or resistant to its renal effects. Now, it is a disorder in which there is polyuria. Polyuria means increased urine output. So, when there is increased urine output, the urine is diluted, right? Now, when the urine is diluted, the urine osmolality will be less or more. It will be less. Sorry, it will be more, right? And serum osmolality, serum will be more concentrated, so serum osmolality will be less due to decreased collecting tubule water reabsorption. Now, ADH usually acts on the collecting tubule. Now, ADH is not acting on the collecting tubule, so water is not getting absorbed in the DCT and the collecting tubule. Hence, there is water loss, right? Now, water absorption is which occurs in the PCT is obligatory, and which occurs in the DCT and the collecting duct is facultative. So there is a defect in the facultative water absorption. So which is induced by either there is decreased ADH, right? There is decreased ADH from the posterior pituitary, or the kidney is resistant to its effects. मतलब ADH is secreted in normal, but the kidney receptors are insensitive or resistant to the ADH secreted by the kidney. By the pituitary. So if you have understood the definition, you will be able to write the clinical features, or you will be at least able to rule out other options related to diabetes insipidus. So clinical features will be urine will be dilute, right? So once you're passing more urine, you will be thirsty. So there will be polyuria and polydipsia. Urine output may range from 2 liter per day in mild cases and up to 10 to 15 liter per day in case of very severe cases. Now because you're losing water, there will be compensatory excessive thirst. Because there is severe dehydration, there may be changes in mentation, there will be insomnia, and there may be weight loss. If left untreated, there is changes in loss of consciousness, tachypnea, tachycardia, and hypotension. So this is due to hypovolemia in short. Patients with nephrogenic diabetes insipidus may also have manifestations related to the underlying disease like lithium toxicity, hypercalcemia, and hypokalemia. May lead to hyponatremia, restlessness, agitation, and seizures. So this is a very important chart. Coming to the difference between central and nephrogenic diabetes insipidus. So the basal urine osmolality is low because the urine is dilute. The basal plasma osmolality is also low. Post water deprivation test, urine in central diabetes insipidus will be low, right? Plasma osmolality post water deprivation test, it will be high in case of central diabetes insipidus. Now what you are doing is the DCT, right? ADH is not getting secreted. So if ADH is not getting secreted, water is not absorbed, and there is loss of water, more loss of water in the urine. Now what you will do is you will deprive the patient of water. So if normally, if the patient is in a water deprived state, the urine output should be low and the plasma osmolality should be compensated. This is a normal compensatory mechanism. Now what is happening over here is, because the ADH is not acting, there is still loss of water into urine despite plasma osmolality being high. So the plasma osmolality will go high. Same in case of nephrogenic diabetes insipidus. ADH is not acting. Now, post water deprivation test, serum AVP levels. Now this is the difference. In case of nephrogenic, it will be high, whereas in case of central diabetes insipidus, it will be low or inappropriately normal. MRI of posterior pituitary will be absent. Bright signal will be absent, may be present in case of nephrogenic diabetes insipidus. Long-term prognosis in case of central diabetes insipidus is usually good. It acquired, if it's congenital, it's good. If it's acquired, it depends on the etiology. Nephrogenic diabetes insipidus, it is usually patients have short stature, mental retardation is commonly seen. So the quality of life is usually poor. Now, based on the clinical features, you can write the complications, right? So, because of there is severe water loss, there is hypernatremia, there is dehydration, and then neurological sequelae like agitation, confusion, seizures, coma ultimately. There will be growth retardation. There will be hydronephrosis due to excessive urine output. So, coming to the investigation and diagnosis of diabetes insipidus, careful history and examination is very important to find out the cause of diabetes insipidus and to decide whether it is treatable or not treatable. There should be documentation of polyuria by the patient, like the urine output should be at least more than 2 liters per day. High normal plasma osmolality and low urine osmolality. Urine is dilute and plasma is concentrated. Higher 24-hour urinary volumes, clear and low specific gravity of urine, low urine osmolality and usually less than that of plasma osmolality. This is very important. Sodium is usually high or higher normal. MRI of pituitary and hypothalamus to determine central diabetes insipidus. The treatment is balanced fluid intake and urinary output, desmopressin. Chlorpropamide increases renal sensitivity to vasopressin, but also increases the risk of hypoglycemia. Chlorpropamide thiazide-like diuretics can also be tried in case of nephrogenic diabetes insipidus and amiloride.